So as I told you that you should complete this assignment. I could see some of these assignments just now received. I'll check it subsequently, and this is very important. Anemia only 2 I have received. I don't know then what new are there. I'll check it and I'll let you know. So these assignments will give you idea. Even earlier, some of the students, they have completed the assignments on drug acting on blood. That time also, I feel that many tend to write very superficial one or just copy paste something which they can immediately find on one or other website. Instead, I will suggest them to refer good book and read it, because assignments are not for me, these are for you. These assignments are there so that you can go through the basics of the topic very well, and then it should be easy for you to understand these things which are given in detail. So let us go for the next topic. Again, I know that I am taking it granted as you have gone through the topic of third year pharmacology, drug acting on blood, and therefore you know all the basic things, pros and cons of each drug, mechanism of action of various drugs and their indications. We are only going to do it fast about various treatment priorities, as we have seen, or first line, second line, or such kind of things, and diagnostic things related to various diseases. So we'll go for DVT today, deep venous thrombosis. Basically, these all are the coagulation defects, we can say, that normally coagulation should not occur, or it should not cause during circulation. Usually it is a mechanism to prevent blood loss during injury. However, when blood start clotting inside the blood vessel, then it causes problem, it causes occlusions, it causes formation of clots, and therefore these obstructions lead to various difficulties. Basically, two important problems they used to occur with this. These are particularly deep venous thrombosis or venous thromboembolism, and another is pulmonary embolisms. They are quite common, and we can see about what are their diagnostic activities, how these are diagnosed. So let us go for their diagnostic assessments. So there are various diagnostic assessments are there. Let us go for this summary for this diagnostic assessment. And see that how this should be used. So there is a one visual summary that is given by NICE. Let us see that. Now there is a test that is called as a 2-level DVT well score. Let us see what are the points which are assigned to this score. So basically it is measuring the coagulation, and this this is diagnostic how it is done. When well score is greater than 2, then it is having likely DVT, and when it is less than 1, then there are little chances that it will be DVT. Okay, so what are the points which are there? The person having either active cancer in last 6 months or already been treated and taking care or palliative care, and that is last stage care. Then person who have suffered paralysis or recent plaster, immobilization of lower extremities, then they have chances. So we will assign 1 point each for that. Then recently bedridden for 3 days or more, major surgery within 12 weeks requiring general or regional anesthesia, and therefore the person is bedridden. Then localized tenderness along the distribution of the deep venous system, entire leg swollen, then calf swelling at least 3 centimeter larger than asymptomatic site. Then there is edema which is confined to the symptomatic leg, collateral superficial veins which are non-varicose, previously documented DVT. These all will have 1 score. So any 2 are positive, that means the person is having DVT. Any 2 of these are positive, that means the person have got higher chances of DVT. And second is we have to minus it. Alternative diagnosis which is there, which is as likely as DVT, but already it is clear, it is confirmed that it is not DVT, then we will go for -2. So when there are 2 points or more, there are chances, and as the point increases, we go for the confirmation that there is a DVT. Okay. So once it is there, go for that, go for various tests. What are various tests we are going for? Go for the ultrasound one. This one ultrasound can within 4 hours of the swelling, then it will show you whether there is a thrombosis in the vein. Quantitative D-dimer test, if it is not already done. D-dimer nowadays very popular, actually, even during COVID. People are testing. It is one of the very important tool to check the coagulability of the blood. If the
Sir, we can't hear you.
Okay. Okay. I'll repeat it fast. So basically this DVT is done. There is a 2-level DVT well score, and it has got points on various things, that is active cancer treatment, paralysis, then recently bedridden for 3 days or more, or there was a major surgery. Normally after major surgery the person is bedridden in last 12 weeks, which require general or regional anesthesia. Localized tenderness. Tenderness means when somebody touch, it causes pain. So along with the distribution of the deep venous system, entire leg is swollen. Then calf is swelling at least 3 centimeter larger than asymptomatic site. That means suppose left and right are there. Left is swollen, then right it should be 3 centimeter larger than the other side. There is edema which is confined to the asymptomatic leg. Collateral superficial veins, the veins are seen superficially, blue color network of vein can be seen, and which are non-varicose of type. Then previously documented DVT. So each is got 1 point. So that means that any of these 2 are positive, then the person has got 2 score, and then the person has likely to have DVT. If already one thing is clear, that is there is something different than DVT, and it is confirmed, it is diagnosed, then we'll reduce -2 from that because of this. And then still if it is score of 2 plus more, then there is a chance that apart from that there is a 1 more DVT is also present. In addition to that, what we are going for, whether this score is good or not, or even if it is less than 1, it is not 2, or even if it is there, then we are going for the quantitative D-dimer test. D-dimer test, I told you, that is, it is for coagulability of the blood. Nowadays, it is very popular during COVID situation, that during COVID also this is taken, because it has been found that COVID virus causes increase in the coagulability, and therefore many people, they suffer because of they are suffering because of this coagulability, and all of a sudden it causes heart attack or stroke like problem, because blood clots are there. So what are the next diagnostic activities apart from this core? Go for the ultrasound scan within 4 hours, or go for D-dimer test immediately, and once it is there, simultaneously go for the interim therapeutic anticoagulation therapy, and again scan within 24 hours. If the scan is positive, then go for the DVT and offer to continue the treatment. That means if scan shows negative, then check again quantitative D-dimer test if it is not already done. If D-dimer is positive, if the score is high, that shows more coagulability, then stop any anticoagulation, repeat scan 6 to 8 later. If again scan is positive, then continue the treatment. If the scan become negative, stop the anticoagulation therapy and then check for other diagnosis in case it is D-dimer negative, or this D-dimer was positive for that period of time, and after 6 to 8 days later we stop the anticoagulation, and then we'll check it what is the situation. So whenever D-dimer is positive, definitely we need to have anticoagulation therapy, because D-dimer positive means there is an increase in the coagulability, so we need to use anticoagulant treatment. So this is how the treatment is to be done. This is how we have to go for the things. Same thing we are going for the pulmonary embolism. That is, we have got again well score, which is 2-level well score. Here there are clinical signs and symptom of DVT are there. Minimum of 1 leg swelling and pain is there. So 3 point we will be assigning. Alternative diagnosis is less likely than this pulmonary embolism. That means that clinician is almost of assurance that there is a pulmonary embolism. Then 3 points. Heart rate is more than 100 beats per more, increase in the heart rate, which is not arrhythmia, again it is confirmed. Immobilization for more than 3 days or surgery in previous 4 weeks, then 1.5. Previous DVT or pulmonary embolism is known, then 1.5. Hemoptysis, that is blood is coming out during vomiting, that is 1 score. Malignancy is known either on treated in last 6 months, or palliative, that means now treatment is removed because the cancer has been reached to advanced stage, and very little chances to get cure. So for that these points are assigned, and accordingly if more than 4 points are there, there are more chances of pulmonary embolism, and if it is less than 4, then there are little chances of this pulmonary embolism. Again same, go for various tests, that is CT pulmonary angiogram, go for that. Interim therapeutic anticoagulation can be given while the result is not come, and if this angiogram shows positive, then diagnose the reason for pulmonary embolism and go for the treatment. Then if the CPTA is negative, then there are chances of only DVT, and then check whatsoever you have done for this DVT earlier, go for that DVT check, and if DVT is not suspected, then stop the anticoagulation and think about the other diagnosis. D-dimer, if it is positive, then definitely one has to go for the treatment, that is anticoagulants. So what will be the anticoagulation treatment for this? Measure the baseline full blood count, renal and hepatic function, then prothrombin time, that is PT, and APTT, that is activated this prothrombin time, and start anticoagulation before the results are available, because don't delay it. Review and if necessary act on the results within 24 hours. Often anticoagulants for at least 3 months. Take into account contraindications, comorbidities, and the person's preference. Then accordingly go for the treatment. Then in various conditions what you are going to use that can be checked. We can have again long-term anticoagulant treatment, which is for the secondary prevention. So this can be again done simultaneously. So what is the initial treatment? We have seen that till that period you are going for till what we can say still you are confirming, still the condition is there, you are going for offering the anticoagulant treatment as an intervention. So go for that, and while going for that, go for the as we have seen, we are going for renal function check, hepatic function and all other data before that. So there is a no renal impairment, there is active cancer is there, but antiphospholipid syndrome or hemodynamic instability is there. Then in this patient, go for apixaban or this rivaroxaban. If these are not suitable, then give low molecular weight heparin for at least 5 days, which is followed by dabigatran or edoxaban. Or you can go for this low molecular weight heparin and this vitamin K antagonist like warfarin for at least 5 days, and until this INR is at least 2 or there on 2 consecutive readings, then you can give this vitamin K antagonist. You know what is vitamin K antagonist? Example of this. Yes, warfarin like or warfarin like drugs. If there is a renal impairment, then check the creatinine clearance, because creatinine clearance is one of the very important sign for the renal function test. If the creatinine is around 15 to 50, then that means it is sort of mild to moderate type of renal impairment. Then go for any of this, go for apixaban or rivaroxaban or low molecular weight heparin for at least 5 days, then either edoxaban or dabigatran. Dabigatran is only if the creatinine clearance is more than 30 ml per minute. Then otherwise you can think about low molecular weight heparin or the this one ultra fractionated heparin or vitamin K antagonist for at least 5 days till INR is around 2 on 2 consecutive readings. And if it is there, then go for this. Is actually the very skillful job whenever this vitamin K antagonist and heparin is used. It is what vitamin K antagonists like warfarin like drugs, they takes time to show the action, and by that time you need to use heparin. And once you reach towards the goal, then you have to constantly monitor INR. You know INR, what is INR? What is this internationalized normalized ratio? What it indicates? On which basis this INR is measured, or what important factors are taken into consideration? Okay, you can go through it. Good, Gayatri, very good. So these are the basic things. So INR has to be checked. If the creatinine clearance is less than 15 ml, that means moderate to severe type of renal failure. In that case, you are going to recommend use of low molecular weight heparin or ultra fractionated heparin, or low molecular weight or ultra fractionated heparin combination along with vitamin K antagonist for 5 days, and then maintain the INR. Particularly, you can see very important thing is whenever you are using vitamin K, you have to maintain the INR to 2, at least 2, and that is 2 consecutive reading. That 2 consecutive reading is not immediately, it is having some gap. So this is always you will be finding. Reason is why? Because as I told you earlier, because of many things it can be fluctuating one, and when INR becomes more than 2 or much more than 2 or much less than 2, then the patient have both chances. Either it can have hypercoagulability and therefore clots and obstruction in blood flow, and which can be very severe, or if it is too less, then it can have severe hemorrhages at certain places, and in both cases the person can become critically ill, and therefore additional care has to be taken. So the anticoagulation has to be offered for around 3 to 6 months, but during cancer cases one has to check about it, whether the tumor size is what is the tumor site, what are the drug interaction with particular anti-cancer drugs, and what is the bleeding risk, and on that basis the drug and therapy has to be confirmed. Then if there is an antiphospholipid syndrome, which because of triple positive established diagnosis, in that cases you offer only this low molecular weight heparin and vitamin K antagonist for at least 5 days, and then once it is stable, then go for that. So these are what various treatments, various options, and these are immediately. Okay, so this is there, which is immediately, and accordingly it has to be done. You can see parallelly other guidelines also on the basis of body weight, how the calculation has to be done, or it is important. Then the hemodynamic stability, particularly in case of pulmonary embolism, is very important. It has to be checked. And INR monitoring, it should be done after self-management or self-monitoring of the INR if it is possible. So these are various things, and if there is a failure of the anticoagulation treatment, then check whether there is adherence, whether any other source of hypercoagulability, increase the dose or change the anticoagulant. And again, those who have read these things properly, then they will realize that particularly I told you in very simple form that these all new drugs, may be dabigatran, apixaban, rivaroxaban, these all drugs are very costly. At many places they may not be even available. So if they are not available, then is one of the problems. So you need to go for warfarin is one thing. Second thing is, even if they are available, they are very costly. Then where the cost is a factor, then another problem. Then third thing is there, that is you have to check the economics of it, and economically if it is possible for the patient to measure the INR routinely, then you can go for warfarin, because warfarin is very economical comparatively, or this warfarin plus this low molecular weight heparin or heparin, they are comparatively economical, and therefore usually it is preferred. And therefore only thing is, when warfarin is given, it has got so many drug interaction and food interaction. I am sure if those who have seen it, they can go through it, they can check the drug interactions, and accordingly the dose has to be maintained, or patient has to be guided well, that if it is the case, if the patient is to be on warfarin, then what they should do about food. which kind of food they can take, which food they should avoid, or if they are taking food, then what care should other care should has to be taken. So this is very important to guide the patient about this. So this is how the immediate treatment is done. Then next is the what should be the other treatments. So this is how what should be the long term treatment one should go for. Okay. So we have seen earlier what are various guidelines are there, what things has to be done. Now we will go for the long term treatment. Now so far we have started with short term treatment, assess this short term treatment, and then check whether it has offered any benefit or not. Accordingly, if there is a benefit, then still consider stopping anticoagulant treatment around 3 to 6 months of the people with active cancer. And if there is a provoked DVT or pulmonary embolism, because of that there is a DVT is there, and if that provoking factor is no longer present and the clinical course has been uncomplicated, then we can observe that if the anticoagulation treatment is stopped, give advice about the risk of recurrence and provide written information on symptoms and sign to look after. So if by chance sign comes, then we can go for treatment again. If there are no such signs, then we can go or we can slowly reduce it. Then in all cases we can do this, and in that conditions we can see that whether the person has got any sign or symptom. And because continuously using this anticoagulant can again makes other problem also. So when if it is not necessary, slowly we can reduce, but again under observation, under full record of the things, whether sign symptoms are there, what are the other thing, because any coagulation related to problem that can cause complications. Then there is one score is there, that is known as a Hasbled score for major bleeding risk, and check this major bleeding risk in the people having anticoagulant treatment, particularly unprovoked proximal DVT or PE. And if this risk is higher one, if the score is more than 4, that means the risk is more, and then here we have to just control it, we have to make it reduced one. There are basically many factors coming in this Hasbled score, that are various bleeding, then how long the bleeding time is there. We know bleeding time, clotting time, which are easy factors, easily measurable factors. Then blood which is coming out from various things like gingival or gums, the blood this is the first there. Then blood which is coming in the digestive system, either in which is passing through stools or it is coming in the vomitus. So on that basis you have got various risk factors, and on the basis you can have that. Once you understand that if the factor is increasing and if the factor is 4 or more, then this anticoagulation has to be stopped because it can risk the person with severe bleeding. Take into account the person's preferences and their clinical situation when selecting anticoagulant for long-term treatment. Those just like earlier we have seen, those which are having renal problem, either and the body weight is less than 50 kg or having weight more than 120 kilogram. So in that cases, if they are having triple phospholipid syndrome or extreme body weight, either less or more, then in that cases we can go for selection. We have seen that warfarin we have used along with heparin in these conditions. Then the people with renal impairment and all this, what just now we have seen, we have preferred the apexaban and rivaroxaban, then we have preferred dabigatran, and then lastly we have preferred heparin and warfarin. So similarly one can think about it and go for this, that is additionally the aspirin can be used for the secondary prevention of DVT. It is off label because basically platelets, they do not make much impact into it, but still therefore it is not indicated. That is aspirin like drugs which are antiplatelet drugs, they are not actually indicated, therefore we call it as a off label use. But recently in March 2020 the guideline shows that yes, you can go for aspirin simultaneously, you can add the aspirin and it should benefit the people. So this is how the activities are there. So thrombolytic treatment, as we have seen, it can be so far we have considered only what heparin, apexaban, or what, these are all anticoagulant treatments. But if required, if it is severe one, then we may need thrombolytic treatment. You know various thrombolytic drugs? Anybody? What are various thrombolytic drugs? Or thrombolytic therapies, example? We have seen somewhere various thrombolytic therapies. Very good. Very good. This is one, and another is surgical or what we can say mechanical intervention. Yes, reticulous, streptokinase. Very good, very good. So these are various agents, this can be used. So if it is very severe one, people with symptomatic iliofemoral, that is iliac and femoral vein is there where there is a DVT, and if the symptom is lasting less than 14 days, good functional status, life expectancy is 1 year or more, and if there is a low risk of bleeding, then one can go for catheter directed thrombolytic therapy. The name indicates, it is easy to understand, catheter directed, that is with catheter it is passed into vein and thrombolytic is added into it, and then this thrombolytic will be or will be causing the dissolution of clot. Same is the case with the pulmonary embolism. The pharmacological systemic thrombolytic therapy, systemic here means intravenous injection. In DVT we have used it what? This is catheter derived, that is through vein, the catheter is passed to the side. Here it is not possible to pass into lungs, that is in pulmonary veins, and therefore it is a systemic thrombolytic therapy for the people with the pulmonary embolism and hemodynamic instability. In that cases we are going to use. Then will not offer any pharmacological systemic thrombolytic therapy for people which are having pulmonary embolism and hemodynamic stability with or without right ventricular dysfunction. So in that cases we are not going to use the thrombolytic therapy. So these are various treatment. Then mechanical interventions are there, that is inferior vena cava filter to people with proximal. So the clinical trials are going on. It's sort of wall like structure is there which will not allow this blood vessel to clot or this blood to clot or veins to occlude. So this type of mechanical what we can say devices which are there, so in that which can be used. So these are various mechanical and other there. Then percutaneous mechanical thrombectomy, just like we have seen in case of cardiovascular PTCA, that is percutaneous thromboplastic angioplasty. Similarly here we can have thrombectomy when that thrombus is removed. We'll put again just angiography and angioplasty we do, or even stroke we have seen this. Similarly we shall be elastic stent like thing will be putting, and that will be making it what we can say removal of the clot, and improvement of the blood flow. Then check the thrombophilia for this patient who are continuing the anticoagulation treatment. Okay. Do not offer testing for hereditary thrombophilia to people, because hereditary already people are having, but testing of the antiphospholipid antibodies in the people who are having unprovoked DVT or pulmonary unprovoked means there was no any reason, no familial history or nothing was there, then you should go for that and check it. If it is planned to stop anticoagulation treatment, then be aware that test can be affected by anticoagulants and specialist advice has to be given, because if this and because of the anticoagulant, this antibodies test may show false positive, false negative like this, and therefore it should be checked in that. So these are the activities which are there. So here we complete DVT and the what we can say pulmonary embolism. Go through these guidelines, the detailed guidelines, read, and I think it should help you to understand. If you have any difficulties about this, you can just write it back. Briefly, we know that it is a hypercoagulated disease. There are various what we can say diagnostic tools using various scales and various other factors, other important ways. And once it is diagnosed or even during diagnosis, which kind of anticoagulant or agents which can cause the thrombolysis, how we are going to use. These are various methods on the basis of the severity of the disease and comorbid condition. If it is comorbid condition is renal failure, either severe or renal impairment, severe or moderate, then accordingly how we are going to use the drugs. These are various guidelines. If on the basis again which are various drugs are available, as I told you what are their pros and cons, and on the basis example we have seen that the newer drugs, they are comparatively having less impact on the INR, but they are very costly, and otherwise the vitamin K antagonist, that is warfarin like drugs, they are comparatively very economical, but they are having chances of fluctuation of INR because of the fluctuation of concentrations, and therefore while selecting this INR measurement will be important, and you have to guide the patient about which drug can have interaction with it and which food can have interaction with it. So in the meanwhile you can prepare this assignment on this, okay, that if it is warfarin, then what will be the impact on the warfarin concentration or INR because of drugs or food, which drug will cause what kind of changes. You can just have a note of it, that will help you to understand it in better way, and various drugs are there. So this is what various scores are there, various diagnostic tools we have seen, and accordingly how we are going for the treatment. So go for this. If you have any difficulty, please let me know. Okay.